Terminology note. The words patient and client are used according to the care setting. Both refer to the person receiving nursing care or support. Nurse brain refers to the practical clinical wisdom and judgment described in this book. For the nurses who are still learning to trust what they notice, and for the seasoned nurses willing to show them how. The moment you begin to see differently. There is a moment in almost every nurse's career when nursing begins to look different. At first, we concentrate on remembering what we were taught. We learn normal ranges, medication indications, side effects, procedures, policies, documentation rules, and the steps of an assessment. We work hard to complete each task correctly because we understand that every detail can affect another person's safety. Then, gradually, something changes. We stop seeing only a blood pressure and begin noticing that it is lower than the patient's usual reading. We stop seeing only a missed meal and begin connecting it with weakness, decreased urine output, a faster pulse, and a change in behavior. We stop assuming that a quiet patient is resting and begin wondering why a person who normally talks throughout breakfast has suddenly stopped speaking. The information has not changed. We have changed. We are beginning to understand what the information means. That development is what I call nurse brain. Nurses have long used the word brain to describe the report sheet they carry during a shift, the folded piece of paper filled with medication times, laboratory results, room numbers, reminders, and hurried notes. That paper helps organize the work outside us. This book is about the brain we develop within us. Nurse brain is the practical wisdom that grows when nursing knowledge meets real people, real uncertainty, and real consequences. It is the ability to notice change, connect seemingly separate findings, recognize what cannot wait, anticipate what might happen next, act safely, and learn from the outcome. It is not a special gift reserved for a few naturally intuitive nurses. It is not a substitute for education, assessment, evidence, policy, or scope of practice. It is not permission to make assumptions because something feels wrong. It is the development of clinical judgment through knowledge, observation, experience, reflection, and continued curiosity. Most importantly, it can be developed deliberately. Knowing the steps is not the same as seeing the situation. Nursing education must begin with information. Before we can recognize a dangerous change, we must understand what is normally expected. Before administering medication, we must know how to verify the order, identify the patient, understand the medication, and complete the necessary safety checks. But real nursing rarely presents one fact or one problem at a time. A patient may have diabetes, dementia, chronic kidney disease, a wound, a blood thinner, poor appetite, and a newly prescribed pain medication. A symptom that seems minor in isolation may become important when it appears beside several other changes. The patient does not arrive with 4 possible answers and 1 clearly correct choice. The nurse must decide what is happening now, what is different from baseline, which findings belong together, what could harm this person first, what information is missing, and what should happen next. This is the space between knowing nursing information and using it wisely. It is also the space where many new nurses feel uncertain. They may know that a temperature is elevated, but not whether the entire clinical picture requires an urgent response. They may know how to give a PRN medication, but not recognize when worsening pain points to a complication instead of a need for another dose. They may know how to call a provider, but hesitate when the first response does not address their concern. The problem is not necessarily a lack of intelligence, compassion, or effort. The missing piece is often an organized way to think.